Welcome back, everyone. I'm Dr. Khan, and today we are diving into the ultimate internal tug of war, autonomic antagonism. Think of your body like a high-performance sports car. You've got the accelerator and you've got the brake. If you can't balance them, you're either crashing or you're never leaving the driveway.
I like the car analogy, Dr. Khan, but for the boards, we have to be more specific. We're talking about the autonomic nervous system, or ANS. It's split into the sympathetic thoracolumbar outflow and the parasympathetic craniosacral outflow. Antagonism is how these two divisions produce opposing effects to maintain homeostasis.
Exactly. It's all about balance. Let's look at a clinical scenario. We have a 65-year-old man in the ER. He's got crushing chest pain, a classic myocardial infarction. His heart is racing, he's sweating, and his pupils are wide. Dr. Sarah, why is his heart trying to beat out of his chest when he's literally lying on a gurney?
That is the sympathetic division in overdrive. Clinically, the body perceives the MI as a massive stressor, the ultimate fight or flight moment. It releases norepinephrine, which hits the beta-1 receptors on the heart. This increases the heart rate and the force of contraction. On a board exam, they'll want you to know that this is a positive chronotropic and inotropic effect.
Right, but why does this matter clinically? In an MI, a racing fart is actually the enemy. It's like redlining that sports car when the engine is already smoking. More beats per minute means the heart needs more oxygen, which it isn't getting because the coronary arteries are blocked. That's why we often use beta blockers, to artificially lean on the brake and counteract that sympathetic surge.
And the brake you're referring to is the parasympathetic system. While the sympathetic uses the sympathetic trunk, the parasympathetic mainly uses the vagus nerve, or cranial nerve 10, to reach the heart. It releases acetylcholine on muscarinic M2 receptors to slow things down. High yield tip: the vagus nerve slows the heart, but it doesn't really affect the strength of the contraction in the ventricles as much as it affects the SA node rate.
Great point. Now let's move from the chest to the face. Our MI patient has dilated pupils. I call this the deer in the headlights look. Dr. Sarah, what's the academic breakdown there?
That's mydriasis. The sympathetic system stimulates the dilator pupillae muscle via alpha-1 receptors. It's designed to let in more light so you can see the lion you're supposed to be running from. On the flip side, the parasympathetic system handles meiosis, constricting the pupil via the oculomotor nerve, CN3, and M3 receptors. It's the rest and digest setting.
I use an analogy for my students. Sympathetic is like a wide-angle lens for a panoramic view of danger. Parasympathetic is like the macro lens for reading a book at home. Why does this matter clinically? If you see a patient with pinpoint pupils, you might be looking at an opioid overdose or a bridge of the brainstem called the pons being damaged because the sympathetic dilation pathway is blocked or the parasympathetic constriction is unopposed.
And don't forget the digest part of rest and digest. Let's talk peristalsis. The GI tract is one of the clearest examples of this antagonism. Dr. Khan, what happens to your gut when you're in that fight or flight state?
It shuts down. If a bear is chasing you, you don't want your body spending energy digesting that turkey sandwich you had for lunch. The sympathetic system decreases peristalsis and constricts the sphincters. It's essentially putting the kitchen on a closed for business sign.
Exactly. Academically, the parasympathetic system is the doctor of choice for the digestive tract. It uses the vagus nerve and S2, S4 pelvic splanchnic nerves to increase motility and relax those sphincters so food can actually move. For the boards, remember that acetylcholine is the primary excitatory neurotransmitter here, acting on M3 receptors.
Wait, did you say S2, S4? That's the craniosacral part of the parasympathetic outflow you mentioned earlier. It's funny how the very top and very bottom of the spinal cord team up to handle the internal chores, while the middle, the thoracolumbar, handles the emergencies.
Precisely. And we should mention one more clinical sign from our MI patient: gooseflesh. The text mentions that shock and sympathetic overactivity cause the erector pili muscles to contract. That's a purely sympathetic response. There is actually no parasympathetic antagonist for your hair follicles or your sweat glands.
That's a huge clinical pearl. If a patient is cold, pale, and has goosebumps while sitting in a warm ER, they aren't cold, they are in shock. Their sympathetic system is screaming. Why does this matter clinically? Because it tells you the patient's gas pedal is stuck to the floor, and you need to figure out why before the engine blows.
To wrap this up for the students, focus on the receptors. Heart is beta-1 for sympathetic, M2 for parasympathetic. Pupils are alpha-1 for dilation, M3 for constriction. GI tract is generally alpha-beta to slow down and M3 to speed up.
Great summary. Just remember, folks, your body is always trying to find that sweet spot between the lion chase and the Sunday nap. When that balance breaks, that's when they come to see us in the clinic.
The takeaway? Autonomic antagonism isn't just about on and off. It's about the precise, receptor-driven coordination that keeps us alive. We'll see you in the next episode.